Okay, basically, pancreatic resection is the only treatment option that can lead to meaningful prolonged survival in pancreatic cancer. In some instances, it can even offer a chance of a cure. We now operate on chronic pancreatitis more than we did before. Over the past 2 decades, with technical advances and centralization of care, pancreatic surgery has evolved into a safe procedure with mortality rates less than 5%. But we still see a lot of morbidity associated with pancreatic surgery. It is no doubt a very formidable operation. It's a technical challenge to the surgeons, and it's a substantial logistical strain on the health resources. If you look at all the early series that were published, the post-operative morbidity in patients after pancreatic surgery was around 60%, and the mortality used to be 25%. And if you look at more recent series in big centers, you see that we have brought down the mortality to less than 5%. We offer now surgery to a lot of patients with chronic pancreatitis with the goal of relieving intractable pain as well as decompressing the obstructed pancreatic duct and the surrounding organs. So who should perform pancreatic surgery? We now have a better understanding of pancreatic diseases. We really work them up very carefully, preoperatively. There are lots of advances made in the diagnostics of pancreas. There's better patient selection, and it is a it's a more individualized approach now. It's very disease specific, but perhaps one of the most critical contributing factors is the concept of centralization. This stemmed from the recognition of the association between high patient volumes and a good outcome. So, if you look at all the literature, you realize that it's the high volume hospitals that have a lower mortality rate. And very interestingly, it is regardless of the surgeon volume. So even if the surgeon does a huge number of procedures, he may not be able to bring down the mortality, but it is the center, it's a teamwork that is important. And the high volume hospitals will always have a broader range of specialists. They are better staffed with intensive care units. They have a high level of experience in the various departments, because to manage a patient after pancreatic surgery, you need many departments to be involved. And also it has been shown now from studies that this also prolongs the survival of the patient. Now, my colleagues here have spoken about pancreatic leak. Basically, the incidence is between 0 to 13%, and pancreatic leaks can be associated with mortality. There have been lots of publications with definitions about a leak, but what I would say to you is, in what is written in red, the patients you will see in primary care are the ones sent home with a drain. So we know they had a leak, but patients will be sent home only when we are sure there is no continuing sepsis and patients have an adequate nutritional intake. And obviously these drains will come out once the leak stops, but quite often you can't keep the patient in hospital for too long. And if they are safe, in a safe environment, we like them to go home. Intra-abdominal abscesses can occur after surgery in 1 to 12% of patients. This often manifests as collections under the diaphragm or under the liver. And again, I would like to say that patients, when we send them out into the community, can present with fever, abdominal discomfort, inability to eat, but we don't send them, meaning we send them when they're very safe, but these things can occur later. And if you find any of these things, it is so important to be in touch with the surgical team at Royal Surrey or your local hospital through the emergency surgeon on call. And hemorrhage can be either very early. The incidence of hemorrhage is 3 to 13% after surgery, but you do get an early incidence of reactionary hemorrhage within 24 hours. And this is usually secondary to either a slipped ligature or bleeding from a join up or something, which we deal with when the patient is in hospital. But you get a delayed hemorrhage maybe 1 to 3 weeks later, where the patient may be in the community, and often this is a very sinister, there's always a sinister underlying cause for a bleed, like an anastomotic leak or digestion of a major blood vessel or suture. And it is extremely important that if the patient presents to you, that you refer them straight to the hospital, because they could present with either abdominal pain, they may be looking extremely pale, some of them may be unstable. If they're unstable, they have to be immediately resuscitated. So I would say even hematemesis or melena post-op after pancreatic surgery is indeed very significant and shouldn't be managed by the GP like any other hematemesis or melena. It should be, the patient should be sent to hospital immediately. As we have treated most of the complications or got over most of the complications, we now realize that delayed gastric emptying is really holding us back. And there are quite a good number of patients, 8 to 45%, who will have delayed gastric emptying after pancreatic surgery. But we have a fantastic dietetic team here who's fully dedicated to making sure that these patients, when they go out into the community, they're not nutritionally depleted, and the other thing is they're constantly monitored on an outpatient basis. And Mary Phillips, who is the president of the Pancreatic Society, is our chief HPB dietitian, and she will ensure to no length that every single patient's nutrition status is absolutely well monitored. Even their vitamin and other nutritional deficiencies are looked at very closely. So we are very proud of our HPB dietetic unit. Now, the feedback that I had from local GPs when I spoke to them was quite often they don't have the knowledge about the procedure that was carried out. Patients requesting information despite being told on discharge, sometimes they do forget and they don't understand the procedures that were carried out. So the patients will go to the GP and say, I don't know what was carried out. I have this drain coming by my side. I don't know how long this is going to last. What should I do with it? And the GPs obviously are concerned, but they are not able to give them an answer. Then some of the GPs said to me when I phoned them that nutritional status was again a problem because they were not sure how long the enteral feeding would be going on for and all that. But I must say that we give an extremely good feedback to patients. But I think when the patients get discharged, they get a bit concerned not knowing the end point or the end goal. Abdominal pain and the right type of analgesia is also important, and we do emphasize about the different things that should be had by the patient. Obviously, if there's nausea and vomiting and the patient is fully dependent on oral feeding, then we got to know pretty quickly before they lose ground. Wound care and dressings, again, was brought up by some GPs saying we're sometimes not sure about wound management. But all these factors, I can promise you, are closely looked at. We also have a special short clinic where patients can come up to the ward and we can see them if there are concerns without having to wait for our Monday morning clinics. So I would like to end here, but I would really like to take some questions from the GPs so that we can actually see if there were any other concerns you have or any other issues you would like to discuss. Thank you very much.